I'm Tony Lembke. I'm in North Coast, New South Wales. I'm a GP at the Austinville Clinic and Chair of Faculty at the Improvement Foundation Australia. And for today's purposes, I'm also Director of the Australian Centre for the Medical Home. So welcome everybody to our qiCommunity webinar for July. We've got a special guest with us, and I'll get you to introduce yourself, special guest.
Hi everyone, I'm Dan Ewald and I'm a GP in Far North Coast of New South Wales in and Lennox Head, and the lead clinical advisor for the North Coast Primary Health Network. And one of the things we're very keen on is helping practices transition to become patient-centred medical homes, and that's what we're on about today.
We're talking about the patient-centred medical home. We're going to talk about why it's relevant to the Australian health system and talk about a quality improvement approach to developing a patient-centred medical home and look at specific examples that practices may use. And by way of background, the concept of a medical home has been around since 1967, so it's almost 50 years now, coming out of America where they don't have a strong history of primary care. And we might say that in the Australian context, a medical home is a general practice or Aboriginal medical service that nominates itself as being, it's chosen by a patient as being as accountable for their ongoing medical care according to 5 key conditions. Dan, is that your thinking around a medical home?
Yeah, it's a new framing of an old model in a way. For many of us, you'll be thinking once we've talked through the details, well, this is old school general practice, perhaps on new steroids, but it's the concept of an ongoing relationship between a practice and its patients, and it's a very clear responsibility of the patients looking after themselves and the practice helping them do a good job of it.
And one of the reasons we might use this term medical home is because there's a growing body of evidence coming out of America and elsewhere of the advantages of the medical home, the person-centered medical home approach. And Dan, today the Primary Care Collaborative in America released their summary of the evidence for last year, for 2016, looking at 24 of the largest studies around patient-centered medical homes. And I'll get Sarah to pop that in the chat panel, the address for that, a large meta-analysis of the evidence that is available for adopting this accountable model for primary health care. And so that's always of interest when that comes out every year. Dan, is it important in Australia?
It is important, and for the same reasons that it's important for many countries in the world, that we have this shared, what the New Zealanders call the burning platform, well, I learned it from them, where we've got the ageing population, we've got increasing levels of complexity, we've got skyrocketing costs in healthcare, skyrocketing expectations, and we don't have an unlimited set of resources with which to meet those increasing demands. So that constitutes a problem, a burning platform. So we need to get, even though we're doing a good job in Australia, we need to get better at it to stay ahead. And being better can take many forms, but we like to think of it with a quadruple bottom line. The goals of being better is to better health outcomes for our communities, better efficiency in delivering the health services, better experience of our patients in receiving services from the health system, and a better experience for the clinicians and the people who work in the health system, feeling like they're doing something good. Coming back to that evidence about what makes a health system work well, and there's pretty clear international evidence that a good health system is built around really strong primary care. And the patient-centred medical home I see as a model for really good primary care. So it's at the heart of a strong health system. And the state and federal governments are recognising this now. That you see patient-centred medical home, healthcare homes in the language at both state and Commonwealth levels. And many would be aware of the healthcare homes trial, and we need to remember to talk about the difference between what we're doing in our primary health network and the Commonwealth Healthcare Homes trials. Let's return to that later.
And when we talk about a person-centred health system, that is one in which a patient and their family can partner, which positions itself clearly at the centre of the health system. They partner with a particular general practitioner over time, supported by a practice team, which consists of other general practitioners, practice nurses, particularly those working in the role of care managers, other behaviouralists such as dietitians and diabetic educators, exercise physiologists, and perhaps pharmacists and people in new roles. And the rest of the health system wraps around that partnership, supporting it as close as we possibly can to the person and their home. That's what you refer to as the medical neighbourhood. Yeah, but Dan, talk to us about the medical neighbourhood. We've talked about the medical home. What's the medical neighbourhood?
So that's the slide. So I think the background of this slide tells the story, which we kind of missed in the video, which people can go onto the website, which we'll have to post a link for. The main health benefits, health outcomes are determined by what happens, what choices an individual makes, and the environment that they have to do it in. So their home is where the big stuff happens. Home is where you choose to be healthy or not in terms of what you eat, whether you exercise, whether you smoke, whether you have unprotected sex, whether you drive too fast when you're drunk. All of that stuff is the big stuff in health. But we know from international work that an enduring relationship with a good primary care provider has great benefits, including some recent work from the UK that again showed that the evidence of a consistent relationship with general practitioners is associated with lower hospital admission rates. And we'll talk more about the general practice and their whole team making the medical home. But then outside of that is what we might call the healthcare neighbourhood. And there's all the other services that a person may need from time to time. Most of the time, they won't need them. Some patients need an extended care team a lot of the time. You imagine someone with multi-system conditions, multiple long-term conditions, and might be regularly seeing a specialist, regularly using pathology services, radiology services, specialised allied health services, possibly even specialised care coordination support services. And there may be organisations, institutions in that neighbourhood that are providing clinical services or social support services. And then from time to time, making up a very small part of everybody's lives, they may end up in hospital. And that's all part of the neighbourhood. And I like to think about the neighbourhood needing to work well to make a good system. One of the features we can think about is care delivered out in the hospital layer tends to be partialist, typically organ specific. It's temporary, it's high cost, it's not where people really want to be. Care at the home is the archetype of holistic, continuing and preferred, and care from the medical home is closer to that. So it's continuing, more likely to be holistic and enduring relationships, tending to be low cost, tending to be preferred.
So Dan, if we're developing high quality general practices that are comprehensive and accessible, we're only getting partial bang for our buck unless the rest of the health system acknowledges the existence of those practices and works to support them through communications channels, education and better pathways. And that's what you mean by the medical neighbourhood.
Yes, it works two ways. The medical home layers have to be very good at connecting people to the other services in a timely way, to the right service at the right time. Whereas the all layers should be working on strengthening the ability, the capacity and quality of the inner layers. Ultimately, we want the person to be really expert at looking after themselves. We want their carers to be really expert at helping them do that. Similarly, specialist services and hospital services should be helping the primary care services be really good at helping people look after themselves and managing them without needing to end up in hospital. So in the neighbourhood, we have a responsibility to help support the other layers do their job, and that includes helping build the capacity of the inner layers, but also helping that the right people and the right information get to the right players at the right time. So,
and
to quote you, Tony, you described the three jobs. We have our work to do for the patient, which we do as great clinicians that we all are. We have our work to do with our own team, so that our team's doing a really good job and working cohesively in an integrated way. But we have the work also to do to make the rest of this health system, to optimise how well the rest of the health system can do its job.
And from the patient's point of view then, in a person-centred health system, Dan, they'll experience care is delivered by one team. That's the ideal, so that they'll have their core team of health providers that in primary care and general practice that they set their medical home, and that will expand and contract depending on their clinical need. But instead is a patient feeling they're moving from a cardiology team to a gastro team to a hospital team back to a general practice team. In a well-performing health system, it feel from the patient to the one team, including their time in hospital, where there's GP in-reach into the hospital during their admission, and there's appropriate support for discharge back into the community. That's our ideal.
Yeah, so that's the 5-minute tour of the concept of a person-centred health system and where the patient-centred medical home fits as a core part of that health system.
So coming out of the evidence, Dan, as a general practitioner and as our guests on the participants in the webinar are all trying to improve their general practice, the key features of a high-quality general practice as defined in the person-centred medical home literature, there are 5 of them. Dan, did you want to take us through what those 5 key features that we may like to be thinking about are?
So the Americans have refined this probably more than anyone else, and we can think of the qualities or the domains, if you like, of a patient-centred medical home as being one where there's really good access, where the patients can access the health service they need when they need to. There's another category of a continuing commitment to quality improvement, another category of being comprehensive and holistic, and another category that includes the continuity of care. So there's some domains which we use in helping practices choose where they're going to make their first moves for quality improvement. But just noticing on the chat bar, someone's asked, well, what about the patients who don't have a general practice to link to, that it becomes their patient-centred medical home? I guess the big vision is that everybody has one. For just about all of Australia, the patient-centred medical home will be a form of a general practice. That in remote Australia, that may be more like a remote area health service led by highly trained nurses, supported by general practitioners, but for most of us in Australia, this is going to be a general practice. And yes, it's part of the responsibility of building a great health system is that there is equity in access to health services, and hopefully that describes, at least in theory, how the invisible patients are included in this person-centred health system thinking.
So Dan, I want to take us back to, we started looking at how we could support practices to become medical homes to improve their quality in those 5 key domains. And we looked at the Americans have a set of accreditation standards for what makes up a medical home, and we mapped those against the RACGP accreditation standards and worked out a checklist of yes, I'm in, no, where can I check the boxes to see whether we were matching it. We did a lot of work on matching up that accreditation style, and then we chose to scrap all that. We decided that the real joy in redesigning our systems was in that innovation and improvement, not in quality accreditation. So we adopted a different approach, Dan.
We did, particularly in the setting of the Commonwealth Healthcare Homes trial, which we thought was not the whole box and dice. The Commonwealth program is a really interesting and fascinating and to be applauded experiment in changing how financing happens, but it doesn't necessarily do much for ensuring that the practice is becoming more person-centred, more comprehensive, necessarily better coordinated or accessible. And we have found our best engagement with general practice has come through helping them have a really good time gradually getting better, doing quality improvement. Quality improvement can and should be a satisfying process to be in versus setting our PHN, which we can think of for this discussion as a support service for helping practices change. We didn't want to become the accreditation big brother. We didn't want to become the bad cop checking that you'd passed your tests. We wanted to be the friend that helped the practices make these small but ongoing quality improvement changes towards being more of a PCMH. I guess we learned that a lot from the Improvement Foundation.
We did. From our work in the collaboratives was able to inform the way we approach this. And so Dan, we, you and our team developed this quality improvement approach by producing a handbook that outlined some of the features of a practice that was accountable for their patients' care, a guideline to quality improvement, a practical approach to quality improvement practices with the laws of improvement, and a practical, the science behind one goes around improving, delivering care in our practice, and have put together a number of lessons from other practices who have been on this journey and how they improve things in a very practical way. And Dan, you've developed a self-assessment tool that allows practices to see together as a team what areas they would like to work on. Can you tell us a bit about that self-assessment tool and your experience in taking it to practices and discussing it with them?
Sure. Well, let's assume that we all think that becoming a patient-centered medical home is a great thing. And many people working in PHNs or in state health may want to help practices make those changes. The hardest step is often to get people engaged, to get the hearts and minds behind it, because making change is always initially a bit of extra work to then make things better and hopefully make things easier. But you know, to make change takes a bit of effort. And we thought the best way to get people engaged in making some new effort was to let them choose which of these aspects of a patient-centered medical home they were most motivated around. So we didn't want to prescribe, first you must become patient-centered, person-centered, you know, you must develop your clinical leadership, you must then work on the quality of your medical records. We didn't have a snakes and ladders step-by-step program you would move along, but we wanted to leave it open to the practice to choose what they were most motivated about and to help them realise and learn what they as a team they're most motivated about. We set out a self-assessment, which is also in the handbook, which basically lists a number of potential change ideas, if you like, around those core domains of a patient-centered medical home. And we got everyone in the team, the clinicians and the non-clinicians, to rate their own practice, their own subjective rating of where they stand on those things. And then we also asked them, given where you've rated this, which are the areas that you're most motivated to make a change on? And then we'd collate all those reports as individual self-assessments from the practice team, and we take them all out to dinner and we feedback what they've said. And that starts the conversation, and that's really the point of the self-assessment, is not to grade them or credit them or pass them, but it's to trigger the conversations. And then we move into the kinds of conversations that many of the listeners will be familiar with from having worked with Improvement Foundation collaboratives, where we're working on the goals, the measures, the change ideas.
And so some of the ideas that practices come up with that they'd like to work on are not ones that we would have predicted, Dan. We take practices, we acknowledge that practices are doing excellent work in caring for the communities. We acknowledge that they are the only ones who have great experience in what resources they have and the people that they're looking after. But they've come up with lots of things they would like to work on and improve, which is our concept of medical homeness, that it's not a point you reach, but a continuum and a continual state of improvement. And some of those I noticed were the meetings I've been to included improving efficiency at the front desk where it was very crowded. How could they create more space? There was engaging with their local population to inform them better, and the practice have started running educational events on a fortnightly basis for their patients that have been very well received. Other practices wanted to improve the quality of their in-practice meetings. They weren't necessarily things that we would have predicted or told them to do, Dan, when they thought about it themselves.
Also, some of the elements of some of the change ideas in being person-centered, I thought would be a little bit scary, a little bit challenging, but I've been surprised the number of practices who are quite keen to get going with using patient-reported measures, which is great because I think that's a thing that we all need to gain experience in using. So we look forward to helping those practices use tablet-based patient questionnaires, like waiting room questionnaires, to help them learn about patients in ways they weren't hearing face-to-face. And that's also useful, they can get double value out of these activities because it actually ticks off activities that are needed for accreditation. Not that that's our main focus here. We had one practice that decided to adopt web-based bookings as a way to help manage their reception desk pressures and the access elements. We've had some practices have chosen to start with the more predictable things of focusing on the things where they're going to generate more Medicare income, like ensuring that all of their at-risk patients have a full set of care plans, team care arrangements and health assessments, etc., as part of being comprehensive. I don't mind where they start. Many practices, as you would have found in the collaboratives, have to start with a bit of cleaning of the data sets, have to clean their practice records so they can then make their measures work. We don't mind where they start. We want to get them excited about quality improvement and move on from there.
So Dan, and we'll come back to some of those ideas, but I wouldn't mind your comment, please, about having an engaged group of, well, two things. First of all is that previously we have had trouble grabbing whole practices. You may get one or two in a practice interested in improvement, but grabbing whole practices coming to a common idea of what they're trying to improve, that's been rare for us. Have you been able to improve that, do you think, through this process?
Yes, well, thinking back over the decade of Improvement Foundation, there have been various iterations of that where initially members of the practice team were funded to come to WAVE conferences, and that so then 2 or 3 people out of a practice would get all fired up because they'd been to a WAVE workshop, and they'd come back and we would hope that they would spread that enthusiasm throughout the team. We've chosen this initial event of the self-assessment and taking the entire practice team out to dinner. Seems to be very successful. Practices, it's amazing how seldom the whole practice team comes together. Perhaps they come together once a year for a Christmas party and they probably don't want to talk about work, but to come together specifically to talk about their team doing what they do well but doing it even better is a really attractive thing for a practice team. And if someone in the position of a PHN is wondering about what to invest in for general practice engagement, this is perhaps a good thing to look at.
And when you talk to them about the vision of a high quality practice delivering accountable ongoing care and focus on these 5 domains, being person-centered, being comprehensive, coordinated, accessible, and with a focus on quality and safety to whole teams, do they get that? Does that change the way they think?
Absolutely, and the exercise of hearing the other people in their team talk about these issues, which are really about good care, doing a good job, tends to loosen up people's preconceived, sometimes limited breadth of how they think about these issues. And they start to realise that the people, the receptionists on the front desk, have got some really good ideas that the practice owner or the other GPs in the practice just weren't going to think of. And they get excited by that. It's a really nice process to be a part of.
And Dan, I might get a comment. Having an engaged group of practices who are interested in delivering better care for their patients, taking that group of practices to the local health district and saying, we've got this team that want to do good work, how can you support them? You've had some positive feedback from that, and you might mention what's happening with the winter strategy in North Coast, New South Wales as an example.
In many states there will be state-funded community-based nursing staff who specialise in things like respiratory rehab programs, heart failure rehab programs. There may be some other aged care specialised nursing type services or allied health services that desperately need to work with general practice because they can't deliver the ongoing care, and they are desperately trying to get a hold of all the patients that would benefit from their programs, but tend to only get their referrals from the hospital sector rather than from general practice. So there's a group there in state-funded health that are very keen to play their part in what really is the healthcare neighbourhood, and we need to bring them together with these motivated general practice teams, and both sides understand the importance of actually communicating properly. And so then once you get the intention and the culture shifted, then no matter what the information technology platforms available, it starts to be used, and that's what counts. And so you get the practice, the chronic care nurse in the practice is actually on the phone to the cardiac rehab nurse in the state department talking about particular patient's care, and that builds personal relationships which are at the core of building an integrated health system, and that's been really nice to see. Now, for us locally, we've decided to try and turbocharge that a bit, and we're calling it our winter strategy, and we've got 30 of our practices signed up in our northern local health district who will identify their top 20 or 50 high-risk patients and enrol them in a program where they'll get extra support from the practice nurse, which the PHN will fund, the extra hours of practice nursing, and they'll have extra systems in place for integration with the local hospital service. So when they arrive at hospital, if they're ever admitted to hospital, there'll be an automatically generated email to the practice to say this patient has been admitted, and that triggers the practice knowing that they can then call into the hospital and do what we call general practice inreach. So the patient is not being severed from their ongoing patient-centred medical home team when they go into hospital. The medical home team knows that this is the time to be calling the hospital and talking about that person's care so that their care team isn't disrupted. It is rather temporarily expanded to include the hospital team. So that's an example of the patient-centred medical home, the person-centred health system being operationalised, if you like, through our work with our LHD, which is the hospital network.
And part of that strategy, Dan, comes to one of Narelle's questions, which is about supporting care coordination and other functions done by practice nurses that often, or that aren't funded under the Medicare scheme. Well, and part of your winner strategy will be support practice nurse time for nominated high risk of hospitalisation patients to spend time each week keeping them out of hospital. Narelle asks about what proportion of funding coming from the healthcare home model would be used for coordination and integration work, and I think it'd be very hard to answer at this stage, but certainly extra funding to improve coordination and integration will be welcomed by general practice.
It's certainly a great way to get engagement of general practice with their primary health network. I want to clarify that the funding we're using is nothing to do with the Commonwealth Healthcare Homes program. We are not one of the Commonwealth Healthcare Homes demonstrations for pilot, was it phase 1 trial regions. We're doing this work separately with underspend money, if you like, from other program areas. And we've also leveraged that funding to get the local health district is also contributing resources to this same program.
It's important to note, Dan, that this is a winter strategy. It's just for 3 months. There's no suggestion that the funding will be maintained after that, which is an advantage, I think. It gives a really tight focus to the work that we're doing. And in answer to Juliet's question, it is being evaluated both at a patient practice and population level. But it's an example, Dan, I think, of once we start thinking about the health system from the patient's point of view as a person-centered health system where they experience care as one team, and we start looking at general practice, the medical home as being the core partner of patients through the health system, then these models become much clearer and obvious to all involved in their care.
Indeed. Any other questions? Are we on a half-hour time frame?
We are, and we are going to close it there now, Dan. Now, we might come back to you, Dan, at a future webinar after the evaluations for the winter strategy are complete. I noticed that I think so thank you, Dan, for telling us about that winter strategy and for your telling us about the quality improvement approach you've taken in the Northern Rivers and North Coast Primary Health Network and Mid-North Coast to supporting practices from where they are to where they want to be. I note there's a problem with the handbook as it's been linked in the materials, but it is available direct download from the ncphn.org.au/medical-home. There's a link there that will allow you to download the handbook.
They can also link through the winter 2017 and see all the resources we're using for that winter strategy work.
Thank you very much for telling us a basic outline of what is a person-centered medical home, the 5 key attributes, and a quality improvement approach to assisting practices who put their hands up to want to improve. And thank you to all our participants. To any practices who want to participate in a medical home project, feel free to welcome either Sarah at the Improvement Foundation or myself or Dan. All the materials available to everybody. It's an open source program. We thank you for participating again in our qiCommunity webinar. Thank you, everybody, and thank you very much, Dan, and thank you, Sarah, at qiCommunity Central.